Now, Sarah always picks these like wonderful, interesting, exciting topics, and then I get to come up and follow her and talk evidence-based medicine. So buckle up, it's going to be exciting. Change is hard. Change is hard in life. Change is especially hard in medicine when the decisions we make are so important. We all know about evidence-based medicine. We know we're supposed to change our practice as these new studies are published as they come along. But we also all know evidence-based medicine sucks, right? Every time a new paper is published, you get some egghead on stage, and every egghead has a different opinion about this paper. You go to a journal club, and every paper sucks. So how do you know when you're actually supposed to change your practice? And I'll admit, I have no bloody clue. I'm not going to answer that question for you today, but what I'm going to try to tackle, in previous years at this conference, I've always given sort of that Papers of the Year talk, and I always found those a little lacking, a little superficial. So the plan from now on, and give us feedback if you like the old way more, but the plan from now on is to just focus on one topic at a time, and it'll be a topic where I personally have changed my practice. A topic that you have probably heard about, but where you're probably on the fence, or at least a large number of you haven't changed your practice yet. And so although this is an evidence-based medicine talk, it really is supposed to be a practical, clinical talk, something you can take home and change your practice tomorrow. So my plan is to give you just enough evidence to give you that nudge and get you off the fence. And this morning, I get to talk about one of my favorite topics in all of medicine, a topic that really has massive potential for our patients in our departments. And it's one of my favorite topics because this belief, the belief that IV antibiotics are somehow stronger than oral, is so widespread in medicine, but it's just so nonsensical. Even from a very basic physiologic level, this concept, the idea that IV antibiotics are better, never made any sense at all. And let me say, I bet you, if we sat down, if we had drinks afterwards, I bet you maybe half the room would say, yeah, I agree with you, Justin. I know that's right. But if we examined your actions, I bet you 95% of this room act as if IV antibiotics are stronger than oral. What do you do when somebody's been on oral antibiotics for 3 days and their cellulitis isn't getting any better? If your answer is I switch them over to IV antibiotics, what you are saying with your actions is I think IV antibiotics are better than oral. That is what you are saying, and I'm here to tell you that every scrap of evidence that exists, every bit of science says you are absolutely wrong. Again, from a basic physiologic perspective, this never made any sense at all. You got a bacteria in your tissues, you got an antibiotic molecule in your tissues, they meet, they do battle. You think the bacteria is like, I don't know, you look like you came in through the stomach. You ain't getting me today, right? Like, it doesn't make any sense at all. And let's get the exceptions out of the way right at the beginning. If you give an IV, it will work about 30 minutes faster on average. And so if we're talking septic shock, if you're sending a patient to Sarah in the ICU, if we're talking neck fash, meningitis, absolutely, give an IV. Those are not the patients we're talking about. And your patient needs to be able to swallow pills. So if they're nonstop vomiting, if they're unconscious, not the patients I'm talking about. Heck, I'll even give you every ICU patient, because maybe they're not perfusing their gut very well. I don't care. Use IV if they're going to the ICU. And there are a tiny percentage of antibiotics that are not absorbed very well from the gut. Not what I'm talking about, but I'll give you a little hint. If they make a pill, sort of by definition, it's got great bioavailability, because otherwise they wouldn't make the pill. We have pills because the pills work. Right? So look at this list. This is my cellulitis list, but Keflex 90 to 100%, Doxy's greater than 90, Clinda's greater than 90. The only one that isn't great is Cipro, so what do? We give a higher dose oral than IV, and so systemically you get the exact same concentrations. Physiologically, it never made any sense at all to think that IV antibiotics were going to be any better than oral. We didn't have to study this. But we've gone ahead and studied this over and over and over again in RCT evidence, and we have proven that oral antibiotics are just as good. So let's start with cellulitis. Cellulitis, I think, probably has the biggest impact on our departments. This is the ones we see over and over and over again. In cellulitis, there are 4 RCTs, and they all say the exact same thing, no difference. Sorry, not no difference. In every RCT ever done, oral antibiotics were better than IV. Better. 3 older antibiotics, not really looking at all like our current antibiotics. These are trials, 3 older trials. These are trials from the 80s. They were using like penicillin, not our current antibiotics, but there's a Cochrane review from 2010, almost 15 years ago, and they conclude statistically significant Oral antibiotics result in a faster resolution of symptoms than IV antibiotics. This is a Cochrane from 13 years ago. Not perfect studies by any means, small, not using our current antibiotics, sure. But we're not talking about equivalence here. Oral antibiotics were better than IV. Let's focus just on the one modern study. This is a single center study. It's a non-inferiority study. The key to know about this study, which makes it really convincing, is these patients were sick. Every single one of these patients had to be referred for IV antibiotics by an emergency doctor. An emergency doctor looked at them and said, you need IV. And the result is 80% of these patients had systemic symptoms. 30% were febrile. These are like sick cellulitis patients, not the garden variety that we see every day. And they randomized them to either Keflex or Ancef. Basically, slightly higher doses than you might be using every day, but these are the doses that I've been using for the last 5 to 10 years based on this literature. And the technical conclusion is that oral is non-inferior to IV, and that is good enough. We just need it to be non-inferior because IVs suck. They're more expensive. They have more harm. So if it's non-inferior, you use oral. That's the right choice. But if you look at the 95% confidence interval, on your right, the worst possible outcome is that IV and oral are exactly identical. The range of possible outcomes are all on the side of oral being better, with extending to as much as oral getting you better a full day better, and the point estimate is oral gets you better a half a day better. Not quite statistically significant, but there is zero chance that IV is better than oral here. And in this study, if anything, is biased against the oral group. The oral group had more fever, higher CRP, higher white counts, and they still did better than the IV group. It's never made any sense at all. IV antibiotics are more expensive, they cause more harm, and there's no reason to think that they would be any better. And this is not just cellulitis. I've been looking basically my entire career. For 10 years, I'm a nerd. I go on PubMed and Google Scholar at least 3 times a year and do this search. I have never found a single paper ever where IV antibiotics beat oral. If you find one, please send it to me because I've been looking. I do not think it exists in all of medicine. I don't think IV antibiotics can beat oral. Pediatric pneumonia, 4 trials, oral is as good as IV, 4 RCTs. Adult pneumonia, 4 RCTs, oral is as good as IV. Pyelonephritis, we got a Cochrane review that'll tell you oral is as good as IV. We got chronic osteomyelitis, Cochrane will tell you oral is as good as IV. Really complex joint and bone infections, we're talking septic arthritis, vertebral discitis. There was the big Oviva study, RCT with 1,000 patients. Oral was non-inferior to IV. Febrile neutropenia, Cochrane says oral is as good as IV. Even in acute infectious endocarditis, there's 1 RCT, oral was as good as IV with less side effects. This never made any sense at all, no physiologic sense, and we have a mountain of RCT evidence that proves that oral is just as good as IV, but actually better, because of course it gets worse. IVs have harms. A peripheral IV itself is a pretty safe procedure, but it is a procedure. And it does have a rate of like 1 in 1,000 of phlebitis or bacteremia from it. And if you're getting no benefit from that, that is 100% pure absolute harm that you're putting your patient through. It's not the one I actually care about, whatever. The harm that really matters is the stuff we see every day, right? These IVs come out. So the patients get poked multiple times. They have to drive back to the hospital. They have to pay for parking. It's bad for our patients. It's also bad for us. Does anybody work in a place that just has excess nursing right now, lots of time? We put these patients back in the triage line. They come 3-4 times a day. They use the triage nursing resources in the hospital. Even if they're just going to a nursing clinic, we're wasting nurses' time across the board when they could just be giving themselves a tab. It makes absolutely no sense. And there's even decent evidence that a single dose of IV antibiotics significantly increases your risk of antibiotic-associated diarrhea and C. diff. We're doing significant harm. This one to me should be really, really easy. It should be simple to get off the fence. Obviously, PO is the way to go. Unless your patient is being rushed to the ICU, unless your patient cannot swallow, there is zero indication for IV antibiotics. Just use pills. So what are you going to do with that patient that has cellulitis for 3 days and they're not getting better on oral antibiotics? Well, the answer is not to just switch them over to IV, because IV and oral are identical. So you're just giving them the exact same treatment. That doesn't make any sense. So you actually have to think, unfortunately, and I know we like automatic algorithms, we got to think a little bit. There is a brief differential diagnosis here. So one of 3 things is happening. Either you got the wrong diagnosis in the first place. If you're starting IV antibiotics on somebody who's got bilateral cellulitis, please stop. You're going down the wrong path. We don't have the right diagnosis here. The other option is that we either pick the wrong antibiotic originally or just the wrong dose. So in skin and soft tissue infections, maybe we needed MRSA coverage. Or what often happens is we just have bigger patients these days. So if they were on the 500 a day of 4 times a day of Keflex, often they need 1,000 4 times a day of Keflex, and that switches it. I do that all the time, just bumping up their Keflex, call them back 36 hours, and they're later. Although even there, I made a mistake, because the most common mistake that we make, especially in cellulitis, is we just don't give patients enough time. If you look at any of the cellulitis studies, patients don't start getting any better. The redness does not go away until about 3 or 3.5 days. So if you're part of that crazy practice of drawing the line on and telling the patient to come back in 24 or 48 hours, I guarantee you it won't look any better. It can't look any better. It doesn't. That's the natural history of the disease. So if you're using that to switch you from oral to IV, you are doing harm to your patients. It doesn't make any sense. Just give them enough time to get better. So that's really all I have to say today. It's a quick talk, simple, one take home. PO is the way to go. Our patients will do much better. Our departments will do better. I think it's pretty clear it's time to get off the fence. That's it. Thank you guys very much.
Thanks, Justin. Thanks, Justin. I think we're all going to miss filling out home care forms.